Hi, this is Pat Iyer. This is a podcast from the Physician-Patient Alliance for Health and Safety. The podcast that we are presenting today is called The Return on Investment of Continuous Patient Monitoring. Welcome to our podcast. And this program is generously supported by Medtronic and EarlySense. As a global leader in medical technology, services, and solutions, Medtronic improves the health and lives of millions of people every year. Our second sponsor is EarlySense. They deliver continuous monitoring solutions designed to enhance proactive patient care for non-ICU general care patients. With me today is Dr. Eyal Zimlichman, a physician who practices in both Israel and the United States. Could you please tell our listeners about your clinical background?
So, my clinical background is I'm a specialist in internal medicine and practice also as a hospitalist at Sheba Medical Center in Israel. Most of my time has been spent doing administrative work and management as the Chief Quality Officer at Sheba Medical Center. I also practice research on quality and patient safety, especially relating to technologies at Brigham and Women's Hospital in Boston, where I worked for 4 years up until 3 years ago.
Terrific. That's an interesting position, and I'm not aware of that being a common position of working in research on quality and safety. Certainly sounds like it would derive a lot of important information for patient care.
Right, and the ability to sort of play between these three worlds of doing clinical work, practicing as a healthcare executive, as chief quality officer, and also doing research in this field, I think gives a very unique ability to go from the research side to the implementation side and understand them both.
Excellent. I know that we've talked a lot in healthcare about evidence-based medicine, and it sounds like you are right there in the middle of it.
Well, we try. That's part of what doing the research is all about, and trying to improve our outcomes through improving patient safety and quality, of course.
I know that you've been working on a project and obtained some results by using a continuous monitoring system on a general medical surgical unit. Could you give us some background about where the study was performed in terms of the locations, the type of hospital, or the types of units that were involved?
Of course. So this specific study was conducted in downtown community hospital in Los Angeles, what we did was we had one study unit, which was a medical surgical unit within that hospital with 33 beds. And we had those continuous monitoring technologies installed, which we'll talk about in a minute, installed at each one of those 33 beds, with the idea that we want to study what an effect would have of being able to have continuous monitoring on general floors, which is, of course, not something that we do normally.
Yes, I'm quite familiar with the technology because of working as a medical surgical nurse for years, just on the type of unit that you were discussing. Why do you think it's important to use continuous patient monitoring systems?
Well, it's first of all, we know from research done in the past 20 or 30 years that usually we could detect maybe 6 to 8 hours in advance before the patient actually goes into cardiac arrest. So there are early signs that can be detected within that time window and will allow us to maybe prevent that fatal event, or mostly fatal event. Once we get to the cardiac arrest, on average we have between 15 to 20% chance of the patient coming out alive. Obviously we want to improve those percentages, and if we want to do this, we have to identify that the patient is deteriorating ahead of time and respond so that we prevent the cardiac arrest. Once we know and understand that there is that window of opportunity, we have to be able to identify it and then act. And we know mostly how to act. We know how to treat sepsis. We know how to treat other conditions that could cause mortality within hospitals. But the problem is with the detection piece. And as we are all aware, mostly in general floors, we have intermittent vital signs checks. These checks would go somewhere between every 6 hours or even 8 hours or sometimes 4 hours, but certainly not continuous. And if that window of opportunity is 6 to 8 hours, we are always in the danger of missing it completely. So by the time of intervention between one vital sign check to the other, we actually would get to the patient bedside only when he goes into cardiac arrest, if that deterioration occurs. So being able to continuously monitor patients on general floors, much like we do on ICUs, could be something that would make a significant contribution to preventing these preventable deaths inside hospitals.
Those are excellent points. And certainly it points out the dangers of the periodic monitoring of vital signs versus continuous. And then also another piece that you didn't mention is that if the vital signs are being monitored periodically, sometimes the person who's taking those vital signs doesn't understand the implications of the patterns that are occurring and doesn't report them, and then the action stops at that level. So I see why continuous monitoring would be so much safer.
Right, and in this specific technology we were looking into, it wasn't just the continuous monitoring, but it also was being able to look on trend alerts. So the alerts were not only threshold alerts, that when you cross a certain threshold on respiration rate or heart rate, the alert sounds, but it also looks at the trend. And if the trend is pointing toward a deterioration in the clinical condition, in hemodynamic condition, the alert goes off. So it's a more sophisticated type of alert, more fitting general floors than maybe the alerts we're seeing in ICUs.
I'm curious about the equipment that you used in the study. Could you describe what it was like? How big is it? What does it monitor? Where does it go on the bed? How is the data displayed? Give our listeners a picture of what this looks like, please.
Sure. So specifically in this study, we were looking at a device manufactured by a company, and it has a couple of attributes that are very important, I think, when we talk about monitoring on general floors. First of all, we're talking about a sensor that is positioned under the mattress. Now, the sensor is a very sensitive piezoelectric sensor, basically saying it measures pressure or movement on the bed in a very, very sensitive way. By doing that, the algorithms that are fitted within this device allow it to identify from the movements, from the pressure differences, the heart rate and the respiration rate, and of course other types of movements that the patient might be doing. And this is quite unique because, first of all, it allows us to monitor heart rate and respiration rate in a non-contact fashion. And if we think about this, when we talk about patients on general floors, this ability is a really fitting attribute because many of these patients want to move around, they don't want to be confined to bed, and if they do want to get out of bed, usually they would ring the nurse that needs to come and unhook them from ECG electrodes or oxygen saturation sensors. In this type of technology, the patient can just get out of bed if he can, and of course that's a big positive, a big advantage of this system. So that's one attribute. Next to the bed, there is a bedside monitor that shows respiration rate and heart rate and movement for that patient. Now, unlike other monitors that show you, for instance, ECG monitors that show you your pulse on a given second, this device gives you the average of the past couple of seconds, whether it's half a minute or 2 minutes for respiration. And in that fashion, that number you see on the screen sort of filters out much of the noise that we see if patient moves, and that affects his heart rate or respiration rate or any other thing that could be an artifact in the measurement. So we filter out many of these artifacts, and the measurement we're seeing is much more accurate or much more actionable. And then when the alert actually sounds, that alert can be either because a threshold was passed on average for points of time, or because a trend alert was activated. And the trend alert looks at the last 24 hours for that patient and gives us a trend alert for that time period of 24 hours. Now, the alert sounds could either be sound on the bedside monitor, it could be sound on a device carried by the nurses, and it could be different types of devices. We were using pagers for the nurses on this, so each nurse got a pager that would alert only for the patients that were assigned to that nurse. And also, at the central nurses station, there was in this study a big monitor that showed all the patients in the ward with their vital signs, movement parameters, and other parameters as we were looking into. As a side point, I would say that apart from measuring heart rate, respiration rate, and motion, there are two other attributes which I won't be talking as much, but only mention here. One of them is an indicator that the patient is high risk for pressure ulcers, of course, with the idea that this would actually prevent pressure ulcers. And another one is an alert preventing falls. We won't be talking about this. This was not part of the study, but it is another attribute of the system.
Okay, terrific. I know that our series has been focusing on the harmful effects of sedation and respiratory depression. Could you explain the clinical impact of those early changes in heart rate, respiratory rate, and oxygenation?
Sure. So one of the things that is critical to mention, and I think it warrants putting 2 or 3 minutes on this, is the issue of respiration rate. Respiration rate, we relate to it many times as the neglected vital sign. The reason we call it a neglected vital sign is because we don't have a good method, a good technology to measure respiration rate currently on most places. What we do is manual counts, and when we do manual counts, many times it's inaccurate. We don't really wait 30 seconds or a minute to actually count respiration rates. As one problem. Second problem is the patient can control his respiration rate, so if he knows we're counting, he could affect it either by breathing quicker or slower. So we have an issue with measuring respiration rate when we do this on point estimates. Unlike blood pressure or heart rate or oxygenation, where we use a device and we take off from the device the measurements. This is being done manually. There is no good technology currently to measure respiration rate outside of sleep labs, unless, of course, we're talking about ventilated patients, and then we have that from the ventilators. So other than that, we're currently measuring respiration rate mostly manually. By being able to measure respiration rate very accurately, as this device does, and doing this continuously, it gives us a hugely important information piece to understand how the patient is doing, and of course, this is very much the case when we talk about sedation. We know from many, many studies that have been done in the last couple of decades that when we talk about patient deterioration, respiration rate plays a vital sign or a major sign in actually identifying those in front. When we have patients going into shock, whether it's because of sepsis, whether it's hemorrhagic shock because the patient might be after surgery and bleeding because of a complication, or if the patient is going into pulmonary emboli, or any of these complications we tend to see in hospitals, most of those, if not all of them, would be shown on a respiration monitor. When we talk about sedation, being able to measure respiration rate with saturation gives us the complete story of how our patient is doing in terms of ventilation. And of course, we're worried about having patients on sedation going into apnea, and that would be captured by this type of device. There are other ways to do it. You could use capnography, of course, which is a great tool for these purposes, but capnography has its own limitations. It's not contactless. It's pretty uncomfortable, and if we need to put this on every patient on a general ward, I think we could only appreciate this would be an issue. So again, coming up with a device that will allow us to do this on all beds in a general floor, and being able to measure ventilation and also oxygenation if we have the patient on oximeter would solve that issue.
I think it would help our listeners if you could share with us a description of somebody whose life was altered by the use of the equipment that you have identified. Could you tell us about somebody that you cared for or was involved in this study who had a positive impact from this?
Sure, I can think about two examples. One is actually in a previous study we've done back in 2008, where we've used this device, but it was in a non-interventional study. Basically, we had the devices recording, but not alerting. And the idea was that we would look retrospectively on how our patients were doing and how they monitored on the device. And I had one specific case in which I was a relatively young person in his 50s, healthy, no other comorbidities, and he came with a bad pneumonia to the emergency department. I was actually the physician in the ED at the time, admitting that patient to the medicine ward. And then, after 2 days, I came to see him in the department, and his condition was much worsened. The patient was on the device, was monitored by the device, but by the alerts were closed at the time because this was a non-interventional study. When we saw the patient's condition was deteriorating, mostly respiratory condition, we sent him to an emergency CT scan, which showed a vast necrotizing pneumonia. The patient was then intubated, transferred to the emergency department, to the ICU, was in the ICU for about 5 days, was extubated and came back to the medicine ward for another 2 weeks in a very poor condition, and then went on to rehab. When we looked back at the data coming from that patient, we could have known 24 hours ahead of when we actually noticed that the patient condition has worsened, that something has gone south. If we would have known that 24 hours ahead of time, if those alerts would have been open, and we would have heard about that, we would have known about that condition 24 hours ahead of time, I would argue that there's a good possibility that maybe his condition wouldn't have deteriorated as much. Maybe he wouldn't need an intubation, wouldn't have gone to the ICU, and the whole course of his acute illness would have been altered. So this is a case where the device was only measuring and not alerting. There's another case, and this is when the device was actually alerting, and we used it when we had a patient who was an alcoholic patient with severe liver cirrhosis, came to the hospital, was hospitalized because of signs of hepatic coma, and after about 2 days on the floors, his condition started deteriorating. We got an alert from the device. We sent the patient to some tests, and we found out that he started bleeding from varices in his esophagus. His hemoglobin came back at about 5 or 6, and we intervened in time and maybe saved his life because of that early warning we got through this. So the patient was losing a lot of blood, went into a hemorrhagic shock slowly, but was diagnosed fairly quickly in the process, I would say. And again, we don't know what would have happened if this was not the case, if we didn't have the device, but I can certainly say that the early warning probably improved his outcome.
Tell us about how continuous patient monitoring impacted the rapid response activations in the facility.
Well, we tend to say now that we've looked into the importance of continuous monitoring, not just on this study, but on other studies and using other technologies, that we think currently, and I think that's the common notion today among the experts, that continuous monitoring is what we call the missing link to making rapid response systems work. And by that I mean, of course, the evidence we had in the last 10, 15 years showing some question marks on the effectiveness of rapid response systems. And, I don't have to remind our listeners of a couple of studies. One huge study done in Australia was published in the Archives of Internal Medicine, and some other smaller studies and meta-analysis that have shown that hospitals after implementation of rapid response systems have not shown an improvement in outcomes, have not shown the decrease in mortality that we were aiming to see. And there was always that question, why is that the case? And if we look closely into rapid response systems, we know that there's an efferent and an afferently, mainly saying that there is, first of all, understanding that there's a need to activate the team. And then once we understand that, there's the actions that the team take. Or how do we get the team to the bedside, and then what does the team do once they're there? So the teams are, this is quite unanimous, are professional enough to know how to handle these cases. They're mostly ICU docs and nurses, and they treat these cases on a day-to-day basis. And when they get to the bedside, generally they know what to do and they can save the patient. The big question and challenge is around getting that teams of professionals to the bedside as soon as possible. And this is where we've been lacking before we started using continuous monitoring. So again, if we talk about the vital signs, the point estimates, we all know that there's a chance that we would be missing the signs of deterioration because we're getting to the patient bedside once every 8 hours for vital signs, for instance. So in that fashion, just having continuous monitoring and being able to have our alert come off earlier than we would have diagnosed that the patient is deteriorating is one huge factor. The second I would like to mention is how the nurses react. So we know, and again, this has been studied in the past, that one cause for making rapid response systems, let's say, not be as efficient or as effective as we'd like them to be, is uncertainty coming from the nurse's side on when to activate the team. Sometimes a nurse, thinks, I'm not sure whether this is justifiable. Sometimes the team comes over and says, this is not a case you should have called for us. You need to think about this again the next time you think about calling us. And that deters the nurses from calling them again, and that hesitation could have negative outcomes on the patients. When we have this kind of devices in place, the alerts that sound and alert the nurses give the nurse an extra layer of confidence that this is an event worth activating the team for. And especially the nurses know some of the data that we've been publishing on this device specifically and other similar devices, saying basically that positive predictive value of these type of devices, when they do alert us, positive predictive value is around 50% mark. Basically saying on every alert we get, there's a 50% chance that this patient would need an ICU. When the nurse gets that alert on top of her clinical judgment, it reinforces her decision making. And I think that factor alone contributes to a better and efficient activation of the system.
Let's talk about the cumulative effect of the equipment alarms, because you've talked about the alerts, and there's a lot of focus now in patient safety circles and in Joint Commission and equipment manufacturers about the alarm fatigue that can occur. How does this system affect that issue?
Well, this is a great question, of course. Alarm fatigue is a huge factor and something we all need to be worried about. And any new technology that comes out has to take this into effect. When we talk, for example, about telemetry, we know the alert fatigue on telemetry is huge. There are cases and sentinel events we all hear about, we read about in papers where a patient was on telemetry because the alert went off so many times. Sometimes the alert thresholds are changed, the alert is turned off or anything like that, or the nurse doesn't react in time because the alert sounds so many times, mostly on false alerts. When we talk about designing new monitoring technologies, we have to be cautious about that. And of course, the new wave of technologies we'll be seeing, of monitoring technologies, is going to be looking more and more into what we call today smart alerts. Smart alerts are alerts that not only signal or alert when a certain threshold has been passed, but they have certain filters that they enact. They have a certain analytic engine that would act on top of numerous vital signs that are monitored, all with the intention of improving the accuracy, reducing false alerts, and improving positive predictive value. Specifically with this monitor, again, and the research we've done, we've shown that positive predictive value, as I've said before, was in the 50 to 60% range, and negative predictive value was 90 to 95%, mainly saying if the device is silent, there's about a 95% chance everything is okay. If it does sound, there's a 50 to 60% chance that this patient would need an ICU transfer. So when you get to these type of rates, this is where we want all of our monitors to be at, or maybe even improved rates, than what we've seen with this as we go into into the future. The other thing is how many times do we have these alerts go off? On average, if we talk about telemetry, a nurse on a shift might be able to get tens, if not more, of alerts per shift. In this specific study, we've looked into that with this specific technology, again, as an indication of how new technologies need to act. And specifically in this trial, what we found was that for every nurse caring for 8 patients per shift, every nurse got 2 alerts on average per shift. One of those alerts was deemed necessary, the other was not. And again, it goes to the 50% positive predictive value we've measured before. So when you get only 2 alerts per shift, you better act when you get that kind of alert. When you get 100 alerts per shift, obviously you get alert fatigue and you might not react timely to every one of those alerts.
And was that 2 alerts per 8 patients or 2 alerts per patient?
Per 8 patients per shift.
Per 8. Okay.
Right.
Okay. Those are manageable numbers.
Exactly. And this is a type of new technology that we want to see come out. This is what the future would look like when we talk about smart alerts and continuous monitoring. And it has to look like this, because if we think about continuously monitoring every patient on medical floors, using the current technologies of telemetry or saturation monitors, we're bound to have hundreds and hundreds of alerts per shift. And that, of course, is not sustainable. So we have to think about new ways to monitor patients.
Another focus in your study, I'm sure, is on the cost of the equipment and the return on the investment of the equipment. Could you give us a sense about how much money you think the equipment saved on this nursing unit that you've been describing to us?
Sure. So first of all, we all know that financially we have to be looking on everything, every new equipment we introduce. We have to understand what's the if we are seeing cost savings, and what's the financial model, and what's the return on investment. And we've utilized the method that was devised by my team in Boston at Brigham and Women's Hospital for calculating return on investment on technologies. And basically what we've seen after we looked at the numbers, and cost savings from this technology is attributed to reducing length of stay in the hospital, on the general floors, in the ICUs, which of course we know every day saved in the ICU means a lot of dollars saved, and reducing pressure ulcers, which was another factor of what we've been looking in a different published paper. So when we factored all of that potential savings and factored in the costs of the technology, we actually have gotten to a break-even point of 6 months, which means after 6 months, after you purchase this technology and implement it, you return your investment on the technology, and then after this period, of course, you actually save money. Now, every financial model and return on investment has to have some sensitivity analysis, because there are ranges and estimates abound here. And when we do a sensitivity analysis and we look at the different estimates, and then we say, well, maybe we're not reducing by X%, maybe it's X minus 10 or X plus 10, and we introduce all that into our calculations. Even though we look at the most conservative models, we still remain with about 9 months of return on investment. I've done some studies on return on investment for other technology, and specifically for health information technology applications in the past, and I could tell you having a return on investment of 6 to 9 months is very, very, very good. We're not seeing this come out of other publications for other types of technologies. EMRs, CPOE systems usually have a return on investment that spans somewhere between 3, 5, maybe 7 years. That's the general rule we see with health information technology. So this is in a different ballgame altogether. And the reason we're seeing this is easy. The reason is the drop in ICU bed utilization and drop in length of stay, mostly in the hospital, And when we talk about prospective payments, when you're being paid by DRG, then that is translated into actual cost savings.
We started talking today about this technology in one unit in Los Angeles with 33 beds. What has happened since that study completed?
Well, there are other studies going on right now. We have a bigger study going on just outside of Boston in one of the partners healthcare hospitals in Newton. That's been going on for more than a year now. We're looking to get the numbers from that one. It's as I said, it's bigger. It's comparing two floors to two floors, and we're anxious to see the results on that one. And then there was another study that just ended at the Netherlands, quite similar to the design of this study that was done in Los Angeles, only a bit of a different healthcare setting because it's a different country, of course. And we're seeing somewhat similar results there also. Of course, this is we haven't published this yet, but I can give the listeners sort of a first feel that the results seem to be similar, although again it's a somewhat different environment, somewhat different incentive systems, and still we're seeing the improvements in drop in ICU utilization and length of stay.
These are very encouraging results, and I thank you for sharing your expertise with our listeners. Is there anything else that you would like to share with us before we conclude this podcast?
Well, I think as a final note, I would reiterate I think the main message, which is the importance of continuous monitoring. I think it's my notion that maybe 10 years from now we'll be seeing continuous monitors on every bed in the hospital. It's in the industry's responsibility and ours as researchers to find the right technology to the right setting. So just figuring out we'll take ICU monitors and just put them on every bed in the hospital, of course, is not the right solution. We have to find the suitable monitors for the general floors, maybe other monitors for an emergency department or for a gastroenterology suite. So every kind of location needs to have the technology that fits that location. And then beyond the hospital, of course, as we go to home monitoring, and that's also one of the fields that's been progressing rapidly in the last few years, we need to figure out better how to do continuous monitoring at home, how to identify those trends and alert for those trends and react early to signs of deterioration. So I think we're entering a very exciting field and exciting time that would show us a lot of improvement in preventing preventable death, which of course is something we're all aiming for.
Wow, that is terrific. This has been Dr. Eyal Zimlichman and Pat Iyer for the Physician-Patient Alliance for Health and Safety. Thank you for joining us in this podcast.
Thank you very much.
This program is generously supported by Medtronic and EarlySense. As a global leader in medical technology, services, and solutions, Medtronic improves the health and lives of millions of people every year. Medtronic believes its deep clinical, therapeutic, and economic expertise can help address the complex challenges such as rising costs, aging populations, and the burden of chronic disease faced by families and healthcare systems today. But Medtronic can't do it alone. That's why Medtronic is committed to partnering in new ways and developing powerful solutions that deliver better patient outcomes. Our second sponsor is EarlySense. They deliver continuous monitoring solutions designed to enhance proactive patient care for non-ICU general care patients. The EarlySense system provides continuous and contact-free monitoring of heart rate, respiratory rate, and motion for early detection of patient deterioration, fall prevention, and pressure ulcer prevention.